So this was pretty much the time when I started working in the field. I visited Brian Dooling. I had the pleasure of spending about 3 years with him in his lab in Charlottesville. When I entered his lab, one of the first experiments that we designed was, again, to look at these capillaries with low red cell content, and then started injecting all kinds of dyes and dye-labeled proteins to see if we could detect any proteins to stick to these heparan sulfate polysaccharide that we figured were on the surface of the endothelium, and then capturing the plasma proteins and creating this immobilized plasma layer called glycocalyx that would occupy a lot of the volume and being responsible for the low red cell content. So within the dotted area, I would turn on a high intensity light source to excite the fluorescent dyes attached to the proteins and to see if these proteins would stick to the wall. While after trying for a long time, up to 2 years, we couldn't see any of the different proteins stick to the wall. And then at some point we started realizing that if we looked at the red cell content before and after we turned on the light source, so this is about 1 or 2 minutes after we turned on the light source, that although we didn't see any proteins stick to the wall within the dotted area, then within that time frame of 1 to 2 minutes, suddenly the red cell content would double or triple. And also the shape of the red cells would change. So before they would be narrow and there would be a huge distance between the red cells. And after the 1 or 2 minutes of light exposure of the fluorescent dyes in the dotted area, the red cells would significantly widen and the distance between the individual red cells would decrease 2 to 3-fold. And suddenly the red cell content would just double or triple within a minute. And then we realized that if indeed the proteins and the dye-labeled proteins would have been stuck to these polysaccharides of heparan sulfate, occupying a lot of space in the beginning, then apparently that turning on the light would cause a lot of damage and destroy those heparan sulfate polysaccharides, similarly as the heparinase enzyme experiment done by Claude Desjardins together with Brian. So this triggered us to look more closely to see what happens to the red cell column and the labeled plasma column in these segments of capillaries before and after turning on the high intensity light. So a real image of that site within the dotted area before turning on the light is shown here. So on the left, you show a short length of the capillary with 2 red cells being present. And we realized, and we started looking more closely, that these red cells, the width of these red cells was smaller than the inner anatomical diameter of the capillary tube, which is strange because the red cells need to be deformed to fit into the tube to start with, but they were never touching the luminal surface of the wall. There was always this gap of about half a micron or so distance between the edge of the red cells and the luminal surface of the endothelium. Similarly, if we measured the width of the dye-labeled protein column that was flowing with the red cells through the capillary, and also the width of that flowing plasma column was significantly smaller than the inner anatomical diameter of the capillaries. Then again, if we look at the same capillary segment after turning on the high-intensity light for 1 or 2 minutes, then you get the image as shown on the right. This is the same capillary segment, but now after 1 or 2 minutes of turning on the high-intensity light, suddenly more red cells now fit into the same segment, so the red cell content pretty much doubled. And also the width of the red cell, the plasma column, increased significantly, now filling completely the inner anatomical diameter. So the true anatomical diameter of the microvessel didn't change after exposure to the high-intensity light, but on the inside of the capillary tube, now much more volume became available for red cells, and also much more volume became available for the plasma proteins to flow through the capillaries, apparently because of the high intensity light destroying the glycocalyx matrix that was sitting on the endothelium before turning on the high intensity light. Well, we realized now that we had to look more carefully, measure the width of the red cell column to get a more functional estimate of the dimension of that glycocalyx matrix in between. And also we realized if you use smaller tracer particles, smaller than the plasma proteins, that some very small dye-labeled molecules, if you inject them into the bloodstream, they would be able to slowly leak into glycocalyx compartment, and now being able to generate a positive stain as shown in this image. So this is an image that you can get if you inject a relatively small dye-labeled plasma tracer, similarly like a Dextran 40 kilodalton molecule, which is much smaller than the typical size of an albumin molecule. And these smaller dye molecules can now leak into glycocalyx and give you another way of assessing the dimension and the volume of that matrix that's sitting in between the red cell column and the endothelial surface. So this gives us an early tool to start measuring glycocalyx volume, and then also enable us to test what happens with that glycocalyx volume after challenging the health of your microvascular system by different kinds of challenges in healthy volunteers. So these are some of those initial findings on not only the volume of glycocalyx, but also on the impact of different challenges on glycocalyx volume. So this shows you on top, for instance, acute inflammation when the healthy volunteers were exposed to an increase in the level of endotoxin, so the toxic materials from bacteria that can cause sepsis. When they started out with a significant volume on the whole body level of glycocalyx. So again, if you look at glycocalyx volume, and now realizing that glycocalyx volume is about twice the size of the blood volume in the microvasculature, and knowing that in the microvasculature about a liter of blood is present, then you get these kinds of estimates of a whole body glycocalyx volume, predominantly in the microvascular space, of 1 to 2 liters. And then being exposed to an acute inflammation with significantly lower glycocalyx volume. Similarly, hyperglycemia, so high glucose levels, similar as found in people with diabetes, would have a significant negative impact on your glycocalyx volume. And the biggest impact we found in these healthy students that we worked with for these experiments is when we told them to smoke 5 cigarettes within an hour. That had a very significant impact on the dimensions of their glycocalyx. And then again, if they stopped the smoking and they came back a few hours later and they fully recovered back to normal sizes. So different stimuli can challenge and attack and damage your glycocalyx, but your body is very dynamic and can restore your glycocalyx very fast in the absence of these challenges. But sometimes you need more help to help your vessel wall and help your endothelium to restore your glycocalyx in the presence of known and also unknown risk factors that are constantly attacking your glycocalyx. And then again, after having found these data supporting that there is a big glycocalyx taking up a lot of volume between the red cells and the luminal surface of the endothelium, we started working on improved techniques for electron microscopy to take these nice images that really help to convince the rest of the world that indeed a thick glycocalyx is there sitting in between the red cells and the endothelium. And the reason that it took so long for Bernard Vandenberg, one of my students at that time, to get these images with electron microscopy is that the volume fraction occupied by these solid structures, the polysaccharides like the heparin sulfates produced by the endothelium. So the volume fraction of these polysaccharides in the glycocalyx matrix is very small. Only 1 to 2% of the volume is occupied by these polysaccharides. And the rest of the volume is proteins and proteins sucking in water. So most of the volume in a healthy glycocalyx in vivo is occupied by water. Now, one of the first steps in the conventional techniques for making electron microscopic images is to dehydrate your tissues. So that means you have to remove all the water from your tissue samples before you can make your images with standard conventional imaging techniques. Now, if 99% of the volume of glycocalyx consists of water, you can imagine if you take out the water, all these structures that are now sticking up would collapse and disappear on the surface of the membrane. And you would only have a nanometer scale leftover of these polysaccharides. So it took Bernard about 3 to 4 years to develop techniques to stain these polysaccharide structures before dehydration and for collapse of the matrix. So the dye that he used is Alcium blue, and Alcium blue actually binds to the negative charges on the polysaccharides and thereby encapsulates these polysaccharide structures and stabilizes them. So after staining with the Alcium blue dye, the matrix was stabilized, and then you could remove the water for the imaging, and these structures would still maintain their structure and show the full extent of the glycocalyx matrix. So the early experiments with the exclusion of red cells from the endothelium, together with these new and improved electron microscopic imaging techniques, provided enough tools for us and others to start not only measuring the volume of glycocalyx, but also the impact of glycocalyx on endothelial function and what happens when glycocalyx is damaged.